Hello. So today we're going to talk about cerebrovascular diseases. So regarding the etiologies, so in general, cerebrovascular diseases, they're like the third leading cause of death after heart disease and cancers. So that's regarding the epidemiology. So regarding the etiologies, there's two main causes of cerebrovascular disease, and they can be broadly divided into ischemic or hypoxia and hemorrhage. So when we talk about ischemia or hypoxia, it's usually the most common cause of cerebrovascular disease, and it's basically due to the impairment of blood supply of oxygen to the CNS. So the major mechanisms through which this occurs is via thrombosis or embolic occlusion. So within ischemia and hypoxia, you can also have, depending on the region of CNS affected, you can broadly divide it into global and focal. So in global cerebral ischemia, which is more widely known, it's a generalized reduction of cerebral perfusion and of the ischemic or hypoxic encephalopathy. So this can be caused by, for instance, low perfusion due to atherosclerosis, acute decrease in blood flow in situations like shock. It can also be caused by chronic hypoxia, like anemia states, or repeated episodes of hypoglycemia in cases of tumors producing insulin, for instance. And the next one is focal. So if we talk about focal cerebral ischemia, this is a reduced cerebral perfusion to a localized area of the brain. The next one we have is hemorrhage. So regarding hemorrhage, this is mainly due to vascular rupture, and stroke is the term that's usually referring to all of these conditions when the symptoms begin acutely. So in this picture specifically, there's the two different types of strokes. So you have ischemic stroke and hemorrhagic stroke. So as mentioned, ischemic or hypoxic stroke is basically where you have decreased perfusion. So in this picture specifically, there is a atherosclerosis of the artery, and as a result of this, you have ischemia. In the second part of this picture, you have hemorrhagic stroke, as you can see in the picture. It's usually leakage of blood outside the vessel. So thrombosis and embolism have similar consequences, which is loss of oxygen and metabolic substrates. And as a result of this, you have ischemic injury and infarction. So a similar injury occurs when there's complete loss of perfusion, severe hypoxemia, or even profound hypoglycemia, as mentioned. So again, just to make the point ingrained, you have hemorrhage. In the hemorrhage stroke, is usually accompanied by rupture of vessels. So this leads to direct tissue damage, increased intracranial pressure, as well as secondary ischemic injury. So in general, as you know, the brain is a highly oxygen dependent tissue, and that requires a continual supply of blood, which had glucose and oxygen. So there's a specific rule of thumb in which if you devoid neurons, which are the brain cells, if you devoid them of blood for about 10 seconds, they lose their function. And if they're without blood supply for more than 5 minutes, they usually die due to infarction. Right. So when we talk about the brain in a hypoxic state, this can be, for instance, due to functional hypoxia. So this is caused by, for instance, low part pressure of oxygen in the case of high amplitude. It could also be because of impaired oxygen capacity, so like anemia or carbon monoxide poisoning, or even specific toxins that interfere with oxygen use, like cyanide poisoning. Regarding ischemia, so this can be transient or permanent, and this is due to tissue hypoperfusion and can be caused by hypertension, vascular obstruction, or even both. So in this picture on the right, specifically, I want to talk about cerebral autoregulation. So what is cerebral autoregulation? So this is basically the ability of the brain to maintain cerebral blood flow relatively constant. So it's usually about 40 to 60 ml of blood per 100 grams of tissue per minute. And this range is specifically quite wide, and it's between 50 to 150 millimeters of mercury of arterial pressures. So as you can see in this picture, if the autoregulation is mainly at this range, so 50 to 150. However, if it increases greater than 150 or if it decreases less than 150 or less than 50, then the autoregulatory mechanism of cerebral blood flow fails. So regarding global cerebral ischemia, so this is basically widespread ischemic hypoxic injury that occurs in the setting of severe systemic hypotension when when systolic pressures fall below 50 millimeters of mercury, as in the case of cardiac arrest or shock, and it can also occur in, for instance, anemia or repeated episodes of hypoglycemia. So the clinical result itself varies. So in case of mild insult, it's only transient post-ischemic confusional state, and it usually is followed by complete recovery. However, in the more severe cases of global cerebral ischemia, there is widespread neuronal death. So in general, patients who survive may remain severely impaired neurologically and in a persistent vegetative state called coma. However, in other patients, they may meet the clinical criteria of brain death, which is where the patient there's a lack of voluntary and reflex brain and brainstem functions. So these patients, and the patients who are clinically characterized by brain death, they're usually maintained on mechanical ventilation, and their brain gradually undergoes autolysis, resulting in what is known as respiratory brain. So as mentioned, neurons are generally more susceptible to hypoxic injury, and the susceptible ones, like the most re neurons in these regions, like the pyramidal cells of the hippocampus, neocortex, and the Purkinje cells of the cerebellum, they're most metabolically active, and therefore these are the most sensitive to hypoxia. So coming to focal cerebral ischemia, so the cerebral arterial occlusion leads first to focal ischemia and then to infarction in the distribution of the compromised vessels. So there's usually a collateral flow through the circular villus, which can limit damage in some regions. However, in the case of like the thalamus, the basal ganglia, as well as deep white matter, these usually lack collateral vessels and are supplied more by the deep penetrating vessels. As a result of this, since they lack the collateral flow, the damage occurs more quickly. So in the OVR, it's specifically written when there is focal cerebral ischemia less than 24 hours, it's termed as transient ischemic attack, while if it's more than 24 hours, it's known as ischemic stroke. And the damage extent is dependent on the extent of on the existence of collateral blood flow, as mentioned. So regarding ischemic infarct, so the picture on the left over here is basically a picture of global cerebral ischemia, and the macroscopy of this picture is characterized by a swollen brain, so you can see this brain quite swollen, and the gyra itself are quite wide, which are the brain folds, and the sulci itself are also quite narrow, and this is mainly because of the cerebral edema that takes place in cases of ischemia. And the cut surface, which is this, shows the poor demarcation between the gray and white matter. So you can see over here, it's quite difficult to distinguish between the gray and white matter. So microscopically, in an ischemic infarct, the changes that occur can be categorized into three different groups. So you can have early changes, subacute changes, and repair, which is the more later stages. So in the early stages, there's 12 which occurs 12 to 24 hours after the insult. And in this, it's usually characterized by red neurons. So in this picture, in the first image, you can see the red neurons, which are quite small in this picture, but these are basically are characterized by cytoplasmic eosinophilia and late nuclear pycnosis, which is chromatin condensation, and carrier rhexis, which is chromatin fragmentation. You also have the glial cells, which is somewhat affected later, and these are less susceptible than neurons to hypoxia, but they also have similar changes. And these reactions are usually followed by infiltration of neutrophils. So in the subacute changes, which is mainly broadly includes liquefactive necrosis, and this occurs 24 hours to 2 weeks after the insult. And I mentioned this does include liquefactive necrosis, so you have enzymatic lysis of cells and proteins, as well as it's important to note that you have the enzymes from the microglial cells, which actually liquefy the brain. And 3 to 5 days after the insult, you have macrophage influx, vascular proliferation, and reactive gliosis. And in the more than 2 weeks after the insult, you have repair, which is characterized by glial scar, and this involves necrotic tissue removal and reactive fibrillary gliosis. So regarding ischemic strokes, you can have mainly three different types. Technically, it's two because the lacunar infarcts are a part of thrombotic stroke, but they are given its own division because of the specificity. So broadly, you have three types: so thrombotic, embolic, and lacunar infarcts. So thrombotic stroke is usually less common than the embolic type, and thrombotic stroke is due to rupture of an atherosclerotic plaque that forms especially at branch points, and it leads to a superimposed thrombus on the ruptured plaque. So in most cases, the body will usually try to lyse thrombus, but each time it will be lysed, a new thrombus will be formed, and the blood supply won't be able to restore. So as a result of this, you have what is known as a beta infarction at the periphery of the cortex. So regarding embolic stroke, so this is commonly from cardiac mural thrombi, so especially due to atrial fibrillation. So thromboembolic cases can also arise in arteries, most often the atherosclerotic plaques in the carotid arteries or the aortic arch. And these emboli usually tend to lodge where the vessel branches or in areas of stenosis and usually caused by atherosclerosis. So in contrast to thrombotic stroke, when the thromboemboli get lysed, in this case, the blood flows restored to the area and it results in a hemorrhagic infarction in the periphery of the cortex. So there's two important things to note over here in embolic stroke. One is paradoxical embolism and the other one is shower embolism. So a paradoxical embolism is the emboli of venous origin and fat emboli from ruptured bones that may actually cross over to the arterial circulation through a patent foramen ovale and lodge in the brain. On the other hand, a shower embolization is basically emboli blocking numerous vessels, and this again most commonly occurs due to fat embolization following fracture. And last but not least, you have lacunar infarct. So these are the most common type of strokes and result from the occlusion of small penetrating arteries that provide blood to the brain's deep structures. So these may involve the basal ganglia and the thalamus. And these arteries specifically are known as the lenticular striate arteries. And the main reason of this usually occurs due to hyaline arteriosclerosis and associated with benign hypertension or diabetes. And this eventually leads to vessel occlusion and multiple small infarcts. And the result of this is known as the lake-like areas of infarction. So over here in this on the picture on the top, you can see the three different types. So you have a arteriothrombotic cerebral infarction. You have a lacunar infarction, as mentioned, which are the fine blood vessels in the brain becoming more narrow and then they become blocked. And you have the embolic type. So these and in the bottom pictures, I want to direct your attention to the third one. So this is a diffusion-weighted MRI axial image, and you can actually see the multiple areas of diffusion abnormalities, and these usually indicate an acute infarction. So in general, MRIs usually take a longer time, and that's why we usually tend to do CTs to rule out hemorrhagic infarction. Although MRIs can show ischemic infarctions, they usually take quite long time and therefore they're not done in acute setting in emergencies. So these areas in general, the ones that are marked, are present in the bilateral middle cerebral and the left posterior cerebral artery distributions. So the large infarct in the left frontal lobe actually resulted in the patient's symptoms of aphasia and right-sided weakness. And this pattern of multiple acute cortical strokes in different vascular territories usually signifies a shower of emboli, typically from a cardiac source. So in this patient specifically, the source was because of atrial fibrillation. So regarding the hemorrhagic infarct, so macroscopically, these manifest as multiple petechial hemorrhages, and macroscopically, you have the hemorrhagic infarction is quite similar to the ischemic infarction morphology with the addition of blood extravasation. So clinically, it depends on the neurological deficit technically depends on the anatomical area of the brain damage. So for instance, if the frontal lobe is affected, as you know, the frontal lobe is involved in thinking, in concentration, etc. So if the frontal lobe is affected, you'll have difficulties in orientation, judgment, concentration. For instance, if the Broca center is affected, you'll have expressive aphasia. If the Wernicke's area is affected, you'll have receptive aphasia. And if the hippocampus is affected, you'll have anterograde amnesia, which is inability to make new memories. And you also have frontal eye field. If that's affected, the eyes usually look towards the lesion. So regarding the diagnosis of this, initially you want to perform a CT without contrast. So this is like the gold standard in ruling in a hemorrhagic infarction. You can also do an MRI. However, these take, as mentioned, these take quite a long time. So regarding the treatment, so if it's a ischemic stroke, and if the time for the ischemic stroke is within like 4.5 hours, then usually tissue plasminogen activator or TPA is provided. However, these do have specific contraindications as well, so they must be kept in mind. So apart from that, also blood pressure control, treating high risk underlying conditions like cardiac problems, balanced diet, and glycemia is also indicated. So in these pictures specifically, in the first picture over here, labeled A, is a section of the brain showing a large discolored focally hemorrhagic region in the left middle cerebral artery distribution. So you can see this large region over here. So this is a type of hemorrhagic infarction. In the next picture, labeled B, it's an infarct with punctate hemorrhages, and this is actually consistent with what is known as perfusion injury, and this specifically is of the temporal lobe. And in the third image over here, it's an old cystic infarct. So it's this region over here, which shows destruction of the cortex and surrounding gliosis. So that's all for me. Thank you for your time.